Hello and welcome to the National Home Infusion Association's presentation of Home Infusion Basics, Key Principles for Physicians. My name is Ryan Garst, and I am the Senior Director of Clinical Services for NHIA. I received my Doctor of Pharmacy degree from Ohio Northern University and my Master's of Business Administration from Kent State University. I have spent nearly 20 years in post-acute pharmacy leadership roles and have over 12 years of experience in the home infusion and specialty pharmacy field. The objective of this presentation is to provide an overview of home infusion services for physicians. Home infusion providers play a vital role in the healthcare continuum by providing services in the comfort of the patient home, especially during times like we are currently living in with the COVID-19 pandemic. We will cover the background on what home infusion is, what therapies can be provided, who pays for those services, how to refer a patient for services, and the role the home infusion provider plays in the care of the patient. What are the benefits of home infusion? Home infusion allows for patients with infectious diseases, gastroenterological disorders, immune deficiencies, heart failure, and more to receive infused parenteral medications in the comfort of their home. This leads to an increased quality of life due to fewer disruptions for school, work, and other daily activities. Additionally, this reduces the risk of hospital and facility-acquired infections. This too preserves those hospital and facility beds for higher acuity patients. The National Home Infusion Association patient satisfaction scores are greater than 97% in 2019. This indicates that patients getting treatment in their home is a preferred method of treatment. Who provides home infusion? Home infusion providers are specialized closed-door pharmacies with expertise in sterile compounding and clinical management of IV therapies. The team is multidisciplinary, including pharmacists, nurses, and dietitians that work with the home infusion provider as well as the physician to partner in the continuum of care for patients in the home. Who can receive home infusion? Home infusion is safe for most patients, and they can receive medication in the home in a safe and effective manner. Clinicians assess patient appropriateness during the home infusion intake process and communicate any concerns with physicians prior to the initiation of therapy to discuss options to be able to treat. An assessment is performed during this process to ensure the home setting is safe for the patient and the infusion nursing staff, whether or not the patient has storage for medications, electricity, and other vital items that are needed for home infusion, and to ensure that the best patient outcomes are achieved. Therapies that can be delivered in the home include anti-infectives, parenteral nutrition, hydration, pain management, inotropic agents, chemotherapy, immunoglobulin therapy, both intravenous and sub-Q, and biologics used for both chronic and rare diseases. Who pays for home infusion? Commercial payers have the most comprehensive home infusion benefit that is typically covered under the major medical portion of the plan. Copays and deductibles may apply. Medicare Part B has limited coverage to approximately 30 drugs under the DME POS requirement of the use of a durable medical piece of equipment. This is typically an infusion pump. There is a potential for a 20% cost sharing, which can be covered by a secondary policy if the patient has one. Medicare Part D is limited to the drug only. There is no coverage for equipment, supplies, professional pharmacy services, and nursing. Patients can qualify for nursing under the Medicare Part A home health requirement if they are homebound and meet skilled requirements. Patients are typically offered a quote to pay for the non-covered services out of their own pocket. Medicare Advantage plans vary from plan to plan, but typically they model after commercial plans and cover home infusion. However, some do offer no home infusion coverage. Medicaid plans are comprehensive. However, they do vary with different exceptions by state to state. The home infusion providers will provide the benefit verification to the patient as well as the physician prior to initiation of therapy. How is home infusion provided? It is based upon a physician order for treatment. Upon receipt of the order, the home infusion provider will verify insurance coverage for home infusion and provide benefit information to both the patient and the referral source, in this case, the physician. They will perform an assessment for eligibility, design the plan of treatment, prepare and deliver the medication, and coordinate nursing services for patient education and assessments. Referring a patient for home infusion is rather simple. You identify a patient that has a potential need, then you identify a home infusion provider. Some home infusion providers are limited based on the commercial payer a patient may or may not have and the network of in-network and out-of-network providers. You would then submit the referral in a variety of ways, including phone, fax, and other mechanisms, provide clinical history and lab results, and then provide the physician order for the medication. This is an extremely easy process, and just basic information is needed to be submitted to start the referral process. Anything additional can be requested as needed by the home infusion provider. The physician ordering process is rather simple. Many home infusion providers have pre-printed forms that they can fill out and send to the physician for signature. Physicians can also utilize e-prescribing parameters within the state board regulations. They can call in a prescription over the phone, they can fax a prescription in, and even secure email can be used to send information and the orders to the home infusion provider. A home infusion physician prescription is no different than any other prescription, and all we would need is the basic information, and if there was anything missing, the pharmacist can assist with ensuring that we have a legal prescription and we are good to go. To reiterate, the minimum referral information required is demographics and medical history information, reimbursement information or insurance information, a diagnosis for IV therapy, prescriber information, drug and therapy orders, the vascular access that's going to be needed, and a monitoring plan. Providers who don't order IVs may need help with this, and that's what the home infusion provider is there for. We're here to help. The plan of treatment is a comprehensive document that provides an overview of all services the home infusion provider will provide, and in some cases, this will need to be returned with MD signature for billing purposes, and of course, this is dependent on the payer. This plan of treatment will include things like the drug, the catheter type, and any maintenance instructions for flushing and dressing change frequencies, nursing orders to infuse the medication, any labs, special instructions, and goals for therapy. There are a variety of ways that the medication can be infused into a patient via an access device. Typically, the most common are via a PICC line, midline, subcutaneous, and/or implanted port, as well as peripheral infusions. Daily therapies longer than 14 days in duration, such as antibiotics, parenteral nutrition, and hydration, typically can be given via a PICC line or midline, and some of those therapies can also be done via subcutaneous route or implanted ports. Daily therapies less than 14 days can either be done via a peripheral IV line or a midline, and intermittent therapies such as biologic enzymes and immunoglobulin can also be done peripherally or via an implanted port, as well as subcutaneous. Check with your home infusion provider, and except for implanted ports, many vascular access devices can be inserted in the home by the home infusion provider. There are a variety of ways in which the medication can be infused or administered into the patient. The easiest mode of administration is via IV push, and then typically an elastomeric device, and then gravity or dial-a-flow, and then a pump. IV push is the simplest and quickest, anywhere from 3 to 10 minutes on average. Patients can also use a gravity with either a drip chamber and or rate flow regulator to infuse medication in a certain volume over time. We also have elastomeric devices that are non-mechanical but disposable rate flow controlled pumps in which the medication is instilled into what typically is a ball and then is infused over a certain number of mLs per hour in time. We also have syringe pumps and then ambulatory infusion pumps as well. Certain medications will require the use of an ambulatory infusion pump, such as parenteral nutrition. Selection of the appropriate method of administration accounts for the patient's clinical situation, the patient and or caregiver's ability to learn, and payer considerations. Home infusion providers are experts in sterile compounding. Sterile compounding is performed in compliance with the United States Pharmacopoeia or USP 797 standards. Home infusion providers are accredited for quality validation. Therapies are compounded for ease of self-administration. We ensure that there's the compatibility and stability in container closure systems to make sure that there is safety in the patient's home. And we ensure sterility are maintained throughout the storage period. Pharmacists and technicians can specialize in sterile compounding, and many home infusion providers have done so. The care management process results in an individualized therapy design. Each patient receives an individualized therapy plan from both the pharmacist and nurse and a dietitian when applicable. Routine collaboration occurs between these home infusion providers to relay the most current updates and ideas for patient care and or interventions to the physician. The support is not only to a physician on the clinical front. Home infusion providers offer financial assistance for patients who need it to work up to come with the best solutions to provide care for them in the home, the preferred site of care. Pharmacists and nurses are also available for the patient 24 hours a day, 7 days a week. This is an example of a potential patient that could use home infusion services. We have a 54-year-old male who fell during yard work and injured his right leg 10 days ago. The patient went to the physician and was ordered Keflex 500 milligrams twice a day for 10 days and is now back in the MD office for follow-up. The patient has a commercial payer, Blue Cross Blue Shield, has a past medical history of chronic venous insufficiency, hypertension, hyperlipidemia, and atrial fibrillation. The medications are listed that he is on. He has no known drug allergies. His vitals are listed, and of note, a recent BMP shows that he has stage 1 chronic kidney disease and renal insufficiency. The assessment is that the cellulitis is not resolved after a 10-day course of therapy, oral antibiotics. We now are looking at potential IV alternatives for treatment. We know that there are likely pathogens to cause cellulitis, such as gram-positive cocci, including staph, strep, and possibly MRSA. The physician refers the patient to a home infusion provider and works with the pharmacist to come up with options for medication. Those options include vancomycin, tigecycline, eridavancin, or eravacycline. All of these medications would be potentially effective in treating gram-positive cocci, including the staph, strep, and possible MRSA. Vancomycin requires labs in either a midline or PICC line. Tigecycline and eridavancin and eravacycline can all be given peripheral or central. If cultures are obtained, medication changes can be done easily if one of the 4 options is not the preferred medication. First dosing can be given safely and effectively in the home, and this is given by the 2018 Infectious Disease Society of America's OPAT guidelines from 2018 for the safe and effective use of antimicrobials and for first dosing in the home if proper patient assessment is done. At the end, after consultation with the pharmacist, the physician and pharmacist decide that the patient will be covered at 100% and that their out-of-pocket and deductible is met. The decision was made to have a midline inserted in the home by the home infusion provider due to COVID-19 pandemic and keeping patients at home versus in a hospital situation. Upon consultation, the decision was made to put the patient on tigecycline due to the indication for skin and skin structure infections. No renal dosing adjustments are needed, and the ability to use a mini bag plus closed container device, which limits compounding and has up to a 30-day beyond use date, and this reduces delivery needs. Labs will be drawn every 7 days, BMP and a CBC. The dose is 100 milligrams times 1, then 50 milligrams every 12 hours for 10 days. There are nursing visits done both in person and virtually on days 1, 2, 7, and 10. And after 10 days, the patient was seen via telemedicine and the therapy was continued due to resolved cellulitis. In summary, home infusion is a safe and effective treatment option for patients. A wide range of therapies are provided with pharmacist and nurse clinical management. Multidisciplinary collaboration occurs between the physicians, nurses, pharmacists, and dietitians. It is a cost-effective alternative to hospital and long-term care or SNF facilities. Patients have a very high satisfaction rate when receiving home infusion services in the home, and patients become independent, taking responsibility for their own care. For more information, please email info@nhia.org or call 888-206-1432. Thank you.